Gentle disclaimer to all of our listeners. All medical information mentioned in this podcast is purely informational. It is not individualized medical advice. Please follow up with your physician or medical practitioner for individualized care specific to your needs. Thank you. Hello, everyone, and welcome to the Know and Do Better podcast. My name is Dr. Melanie Carminati, and I am your host. Today, we will be chatting about getting to the source of pain, and we are very fortunate because we have Dr. Jason Siefferman here, who is a physiatrist. So, Dr. Siefferman, thank you so much for your time.
Thank you for having me.
For those who don't know Dr. Siefferman, he is board certified in physical medicine and rehabilitation, also known as PMNR, and interventional pain medicine. He is trained to offer a comprehensive diagnostic evaluation and treatment for anyone experiencing pain or a disability. He was published in multiple articles, book chapters, and persuasive essays surrounding many of the conditions that he treats. He completed medical school at Rush Medical College in Chicago, Illinois, and residency and fellowship training at Icahn School of Medicine at Mount Sinai in New York City. He is currently clinical assistant professor in the Department of Anesthesiology, Division of Pain Medicine at New York University School of Medicine. So Dr. Siefferman, thank you so much for being here. I speak about you to my patients by saying that you're an anatomy detective and one who is excellent at differential diagnosis. And I relate to this because I operate in a similar way as a physical therapist. But why don't you just talk a little bit about your process and how you work with your patients?
Most pain is mechanically driven, meaning that there's some structure in the body that's moving in a way that over time tells the body that something doesn't feel right. And it may be a simple overuse injury, maybe an accident-driven injury like a disc herniation or a sprained joint, and it may be as simple as something straightforward and singular like that. But unfortunately, more often, by the time patients get to me, it may have been an initial pain, which then led to compensatory behaviors, meaning they changed the way they use their body. They've adapted other patterns of movement. These other patterns are not as biomechanically advantageous. So in using these other patterns, they end up stressing different structures. And it's almost a snowball. And the snowball just gets bigger and bigger as time goes on. And when I meet this big snowball at the bottom of the mountain, we have to sort of pick it apart and see what, and understand that cascade and understand how that cascade came to happen. And it's a process. It's like untangling a big knot. And we can usually see which thread to pull on first. And we see what happens then, and then we'll see what thread comes next and how to pick that apart. When the pain is anatomically driven, the goal is to identify the anatomy that's involved, right, but not just which anatomy piece is involved, but why it's involved. Because we can't isolate, say there's a disc herniation, for example. We can say, yeah, there's a disc herniation. That's why you're having this pain. But if we don't understand what led to this disc herniating, simply treating the pain from the disc herniation isn't going to keep it from reherniating. And so we're not going to get any sort of long-term benefit from that. So my goal is really to understand how all this came to happen. We talk about like the 5 whys when we're trying to understand a process. It's very much the same thing.
Wonderful. The thread example that you gave, I like that because it feels like that when you presented with different cases, and many times when the pain's been there for over 6 months, years, however long it's been there, there are multiple threads that are there, and just knowing, like you said, which one to pull, which one is going to get you to the root and allow you to help that person heal. I want to have you chat about the different types of regenerative medicine, physiatry services that you provide. I know that some of my patients, first of all, when I tell them about physiatry, they're like, what's physiatry? And then when I start mentioning some of the specialty regenerative medicine procedures that they can receive, they're like, I've never heard of this. Could you touch on that?
Sure. So physiatry is really the medicine of understanding the mechanics of the body. And it encompasses a lot of neurology, orthopedics, rheumatology, physical therapy. It really puts all of these things together from the perspective of a medical doctor. So we're diagnosing systemic processes as well as focal processes. We're looking at treatment regimens that encompass medication options, physical modalities like physical therapy or chiropractor, acupuncture. We're looking at procedural options. And then we're also looking at the psychology of pain, because anything that affects how your body functions affects how your mind feels. It's part of the holistic experience of pain, especially when it's chronic. When it comes to regenerative medicine specifically, if we take it back a step, we identify the problem, we try and understand why it's a problem, how it came to be a problem. The question then is, how do we fix that so it doesn't continue to be a problem? Sometimes the answer is regenerative medicine, not always. Sometimes the answer is steroids. Sometimes the answer is just physical therapy. It's important to understand exactly how it came to be and what's going on so you can help the patient make the best decision and educate them about these different options. So let me talk about the steroid bit first, even though you didn't ask about it, because I feel like that's what everyone is familiar with, having a cortisone injection of some sort.
Absolutely.
If there is a distinct inflammatory process, like gout is a good example, rheumatoid arthritis is a good example. It will happen with psoriatic arthritis and lupus and ankylosing spondylitis, a lot of autoimmune conditions, and also in some osteoarthritis conditions where there's really a bad severe flare. Sometimes the best thing you can do for the patient is just to get them out of the flare. That's where the steroid comes in. We know that steroids used consistently over long periods of time, repetitively, are not good. They have poor long-term outcomes. So we don't use them consistently. The old every 3 months they get a steroid injection is no longer common practice. It's a band-aid that doesn't address the bigger issue of what's going on. There is a role for steroids. There needs to be a conversation that's had because steroid will give the most immediate relief when it's indicated. And of course, there are some situations where steroid will do absolutely nothing except give you the side effects of the steroid. It'll have no therapeutic benefit. So one example is knee meniscal sprain, tear, tweak pathologies affecting the meniscus of the knee that makes it trigger pain. It typically does not respond to steroid for whatever reason. And generally, the meniscus of the knee will become tweaked because the mechanics of the knee are off. And usually what that means is that there's some hypermobility about the joint. And this will happen after a sprain. So there may be a little bit of medial collateral ligament, lateral collateral ligament, ACL or PCL ligament stretch. And this can happen in people who are intrinsically hypermobile, meaning their DNA programs their ligaments to be more stretchy than normal at baseline, or it can happen after an injury. Or it can happen with consistent overuse in a way that repetitively strains that ligament. So what happens? The knee becomes loose. It's not held together as snugly as it should be for that meniscus to be functioning as it should. The bones end up rubbing in a way that push that meniscus or pull at it in a way that cause it to generate pain or cause it to tear or cause it to wear down. And then that will cause inflammation. It'll cause pain. You may get an MRI. It may show that there's a meniscal tear. You have the question of, what do I do about this? There is an indication for surgery in some of these cases. Sometimes there are severe tears which break off and they block the joint range of motion and they're severely limiting. And there's a clear indication for surgery in some of these cases. A lot of people fall in the middle ground where they don't necessarily need surgery. At the same time, it doesn't heal on its own with time. This is really the window for regenerative medicine to shine. In situations where there is ligamentous instability, hypermobility, a sprain of some sort, a chronic ankle sprain is another great example where if someone sprained their ankle, they didn't wrap it and stay off of it for 6 to 8 weeks and they returned to walking on it and it just healed loose. It's not going to function the same as it did before. And because it's not functioning ideally, there will be wear and tear that builds up over time. And we may see them 20 years later when they have ankle arthritis, or we may see them sooner and hopefully stop that process. But the role of regenerative medicine is to really restore the integrity of these structures. Regenerative medicine, it's a broad umbrella. The basic idea is we're triggering the body to heal itself.
Yes.
And there are different ways of doing this. The most basic, oldest, the one you can read about in ancient medical textbooks is prolotherapy. It has been used for centuries. Prolotherapy stands for proliferation therapy. And what we're doing is triggering proliferation of fibroblasts, which are the collagen-producing cells. They're the fibrous-producing cells, the ones that will strengthen ligaments and fascia and make the connective tissue heal. In a place where a ligament is sprained and it's too loose, we can inject prolotherapy and trigger a healing, strengthening, tightening response. This is particularly helpful for hypermobile joints. A number of patients with Ehlers-Danlos who have repetitive shoulder dislocations. Prolotherapy into the joint capsule can tighten up that capsule, and it can help prevent recurrent dislocation. Similarly, in the knee, if there's an ACL sprain that's not bad enough to warrant surgery, but still causes hypermobility that's wearing and tearing that ligament and causing pain intermittently, prolotherapy can be very helpful for tightening up those structures to secure the mechanism of the joint. It can be helpful for tendinitis, tendinopathies, and it can be helpful for just arthritis by itself. The mechanism there is not quite as clear. It's also difficult to tease out, and we don't have studies that tell us all of the deeper understanding on this, because the studies will look at knee osteoarthritis as a group and take all comers. And as anyone who works in this area knows, knee osteoarthritis is multifactorial. There are multiple pieces of the joint that can be arthritic, that can register pain, and there's many reasons why knee arthritis develops. And going back cascade of events, someone comes in with knee pain, we can't just throw something in the joint and expect it to work without understanding why they're having knee. It's understanding that why and treating the why. And that's where, if there's a laxity issue, if there's a ligamentous sprain or a tear issue, that's where prolotherapy can be especially helpful. PRP is probably the next level up, platelet-rich plasma. This is where you draw the blood, spin it down in a centrifuge, and collect the platelets. The platelets are important because they produce growth factors, and growth factors stimulate healing. Platelets live for about 7 days, so we inject them into the area of injury. They stimulate growth proteins, hormones, cytokines. They stimulate an inflammatory cascade. They stimulate healing by that mechanism. PRP is generally much more painful. We can't use local anesthetic with it, or typically we don't, because the local anesthetic affects the platelet function. And we want the platelets to work as well as they possibly can, because also PRP isn't covered by insurance. So if you're spending all of this money, you want it to work. PRP is used in a similar fashion as prolotherapy, but I would say its use is more broad. So it will be used for torn, injured ligaments. It will be used for osteoarthritis in joints, cartilage degeneration. And one thing that's happening now with regenerative medicine in general is that it's just getting thrown everywhere. There are studies looking at intradiscal PRP. So if you have a disc herniation, an annular tear in the disc, can you repair that with PRP? If you can think about it, it's being used. It's being used for hair regeneration, facial rejuvenation. There's a lot of different uses for PRP, being used in the genitals for enhancement there. It's an area of exploration. PRP is more popular because a lot of athletes are using it, and there are companies that produce devices for it that market it as a procedure.
I see.
It gains a lot more traction. It gets a lot more studies because there are companies there to support the studies. As opposed to prolotherapy, there's not a specific pharmaceutical agent that's on patent. So there's no advantage for any company to sponsor a study for it. So dextrose, or sugar, is the most commonly used prolotherapy agent, and it's super cheap. It's sugar. Getting a study for it would have to be through the NIH or some government-funded agency or something like that. The next level up is probably BMAC, or bone marrow aspirate concentrate. And we can talk about mesenchymal stem cells as well, which come from fat. And then the other way people get stem cells is there will be donated stem cells, where you'll have other people's stem cells that were hopefully ethically taken and stored and cleaned before being injected into you. Stem cells are like the laser spine surgery of 10 years ago, right? It's the buzzword that everyone thinks if they can just inject stem cells, it'll fix everything. But you have the same issue with stem cells as you do with PRP or prolotherapy, and it's getting the right treatment at the right source for the right reason in the right environment. There's a lot of factors. If you were to take a cohort of patients with knee osteoarthritis and just randomly throw stem cells into their knee, or randomly throw PRP into their knee, or randomly throw prolotherapy into the knee, you'll have some response from each of them. No one has done a comparative study because, again, there's no financial incentive to differentiate them. Everyone just wants to show that their product is superior. So they'll choose a target that maybe hasn't been studied by the other agents. So it's difficult to compare them. When we're looking at stem cells, if you're using autologous stem cells, which are your body's own stem cells, collecting them is the issue. If you're using bone marrow, it's like doing a bone marrow biopsy. It's done in an operating room in a sterile environment. There's actually an introducer placed into one of your bones, usually the iliac crest, and the bone marrow is aspirated. And this procedure by itself, just as an aspiration of bone marrow, carries risks of infection, risk of embolization, which is when something gets into the bloodstream and goes someplace else. It's not good. There are risks with it. Looking at the effect of the stem cells, it's not clear that they are so superior to PRP or prolotherapy that it warrants the risk of this. But again, like I said, no one's done the study. But because of the risk, because of the procedure involved, because of the machinery involved, it's even more expensive than the PRP. The mesenchymal stem cells typically come from fat, and it's almost like doing a mini liposuction. And then those fat cells are concentrated, and the stem cells from then are then injected. These are used just like all the other stem cells. They're put in tendon tears or muscle injuries, or they're put into joints directly, hoping. I say hoping because we don't have data that solidly supports it, that something will work. There. That's a little bit of a recap of regenerative medicine options.
Yes, there's quite a few options, right? I want to go back before we talk further about that, about what you were saying with how when patients come in, you're wanting to find out the why. Like, why did they get to this point? And I know for myself as a physical therapist, I take pride in being able to do movement analysis and really analyze how the patient is walking, how are they sit to stand, what's their sit to stand like, how are they moving around in bed, and just doing basic functional movements to see how they are carrying themselves in their body. And I am curious, why do you think that it takes so long sometimes for people to get to the proper diagnosis? And can we talk about what happens when it does take that long to get that proper diagnosis?
It's difficult, and you meet patients when you meet them where they are, and it's also you have the benefit of seeing everything they've been through and using that information to help guide your diagnosis. There are so many factors involved. It's also sometimes difficult to see immediately the pattern, and pain will often occur in constellations. So even thinking about knee pain, I'll just keep going back to the same example. There are different patterns by which knee osteoarthritis develops. And with experience, with seeing hundreds of these patients, you learn to recognize the constellation of symptoms. So patellofemoral knee pain is probably a good example here because there's a very specific posture, meaning when they stand, when they walk, there's some valgus at the knee, meaning that the knee bends inward a bit. There's usually some flat foot, meaning the forefoot pronates as they walk. There's a little bit of tibial rotation. There may be a little femoral extroversion. You can see that there's some glute med weakness, and when they walk, their gait's a little bit asymmetric, assuming it's in one knee and not both. You sort of put these things together and you can see what's going on. And they may not present with pain in the knee. They may present with pain in the foot, that you see this whole cascade, or vice versa. They may present with hip pain, but then you see this happening and it's coming from the foot. And once you correct the foot, then the knee gets correct, and it's all biomechanics. So I guess when we look at pain, especially chronic pain, it comes in layers. And part of my job is teasing apart those layers. One layer, I will say, is mechanical. And so everything we've been talking about so far is mechanically driven pain, just meaning the pieces that are connected to each other moving in a way that generates a discomfort. Another layer of pain can be sensitization of the nervous system. Talk about neuropathic pain, and that word is a little clumsy, the way it's used. Let's think about it as sensitization, meaning the nervous system is upregulated, meaning that what might normally not be painful now is perceived as uncomfortable. This is what happens when pain persists. The nervous system adjusts and pays extra attention to that part of the body. It's like, the middle management is knowing some of the workers downstream aren't working appropriately. There's extra scrutiny over that department. This almost puts a cloud of sensitivity around the anatomic structures that are involved. This happens with hip pain. It happens almost always with pelvic pain. It happens frequently with low back pain, with neck pain. And you kind of have to look at the whole picture at this point and see if there is evidence of sensitization. So if light touch is ever uncomfortable, if anything ever feels weird or funky, if the skin touch doesn't feel right, if tight clothing is not tolerated, if a whole area just throbs or aches and it's not focal, this is sensitization. And sensitization often happens through the sympathetic nervous system. The sympathetic nervous system is the fight or flight response. It's the same part of the nervous system that innervates the viscera, meaning the internal organs. So like the uterus, the bladder, the colon, the gut, it's all sympathetically innervated. The discs in the neck and the back are sympathetically innervated. The nerves peripherally don't have a lot of sympathetic fibers, but when they become injured, the sympathetic nervous system becomes involved and they become sensitized through that pathway. If there is a pain on a structure, but the whole area around the structure is amplified, we want to understand how that's happening. And that means, why is it happening? What's driving it? What's feeding the fire? And where is it happening anatomically? Because in the sympathetic nervous system, there are hubs. Sometimes it's just one hub that's upregulated. Sometimes it's many hubs. And I explain it often spreads like California wildfire. It may start in one area, but will rapidly spread. The analogy of a fire is actually a good one here, because with sympathetically mediated pain or sensitization of the nervous system, there's a fire. And patient often described like there are alarm bells going off in my body. Think about it as a big fire. The flames are burning so big you can't actually see what's on fire, That's what sympathetic pain is like. That's what sensitization is like. So if that's happening, my first step is to try and control the sensitization, try and put those flames down. So if we can knock the flames down, then we can see the embers that were generating the flames, and then we know what to go after.
I love that image. Was recently at the International Pelvic Pain Society conference where there were a bunch of presentations on central sensitization. They did speak heavily about endometriosis and central sensitization, but also in general, just across the board with any kind of chronic or persistent pain. I think it's really important for patients to understand. I know in my practice, we do a lot of education about the biopsychosocial model. That's one of the models in physical therapy that we use when explaining the experience of pain, having a painful experience, and that trifecta that's influencing the painful experience that the patient might be going through. I know in your office, you have psychotherapy as well. That's a big part of managing pain for the central sensitization. There's even some screening, some outcome measures that we use with patients here in my office. And one of the things that, if the score is above a certain amount, that is recommended is to do cognitive behavioral therapy, because making sure that the thoughts that the patients are having are in line to allow for healing. Because if they're in that sympathetic overdrive, many times the thoughts surrounding pain and the experience in their body and whatever might be injured are not conducive for healing and allowing for the neuroplastic changes that might need to happen for them to get out of that painful state. In your office, when you have a psychotherapist there, how does that work in your office? How do you collaborate with the psychotherapist and even other practitioners? We work together with patient care.
If there is a need for psychotherapy or room to benefit from psychotherapy, we'll introduce them to the psychotherapist. Both of the ones that we work with are specialists in pain from different angles. So Dr. Wolkin is a neuropsychologist who then specialized in pain. Mm-hmm. And then Dr. Gary is more of a traditional psychologist who then studied a lot of Eastern medicine. She's also a licensed acupuncturist, and she's very familiar with the pain and the mind-body connection. And she will actually use acupuncture to evoke some of those viscerally encoded emotional storage areas, which I think is fascinating. The psychology of pain is complex, to say the least. The most superficial and introductory way that pain psychology can be helpful is learning cognitive behavioral therapy techniques to divert your panic response when you feel pain coming on. It's a way of acknowledging, yes, I feel you. Yes, I hear you. I know what you are. I have to focus on this other thing. So yeah, I'll talk to you later. At a more complex level, of course, using self-hypnosis, ways of reassuring your body, doing biofeedback techniques, breathing techniques, things like that, where you can down-regulate your autonomic response. Mm-hmm. At a deeper level, when there is pain, especially with chronic pain, there may have been an injury or an incident that led to the development of the pain. That initial event can be a source of trauma or PTSD. Add on to that the chronicity of pain, the missed life events, the altered trajectory of their hopes and dreams. And there's a lot of anger, a lot of resentment, a lot of justifiable unhappiness with how this has driven the course of their life, and they are still in pain. There's a lot there. A lot of patients, when they're fighting, they are in the moment, they are fighting the fight, they are doing everything they can just to hold it all together, but there's this piece where they are not who they really are. They're not able to fulfill what they thought they would. And there's an adaptation to this, but then once they're past it, once they're at a point where they find some relief, there's also sort of a reconciliation, a looking back, and that is its own adjustment period. Once somebody has been through this journey of chronic pain and they find a solution and they feel it's like, whoa, what did I just go through? What was all of this, right? And it's almost a bit of anxiety that settles in, because it's like, well, what now? What does this make me? Who am I as a person now that I've been through all this? But what if it happens again? That again, there are many layers through the pain journey that the psychologist can be tremendously helpful with.
At the same conference I just mentioned, the IPPS conference, there was one poster presentation that spoke about vulvodynia and how the presence of chronic vulvodynia requires, a grieving process of identity, in some ways. So it is complex because of all the things that you mentioned, all of those all of those experiences. And I want to talk about some research or any other techniques that you're incorporating with your patients.
Much of pain, as you know, is the Wild West. It's incredibly difficult to study pain because you can't find 100 patients that are exactly the same. Even if you take 100 L5S1 disc herniations, they will all present differently. They'll all respond to different treatments. They'll all take a different treatment course. It's very, very difficult to be able to study any one thing in particular just because of that, just because of the heterogeneity of pain. So much of what we do is individualized care, and it really comes down to understanding your particular patient and what's going on, why it's happening, how do we get them out of that. There are very standardized sort of steps for doing peripheral nerve blocks versus central nerve blocks versus ablations versus spinal cord stimulators, things like that. One thing I will speak about, there is more recent evidence for spinal cord stimulation for pelvic pain. It's wonderful because, so far there's not a lot of good evidence for neuromodulation for pelvic pain. But the dorsal root ganglion stimulators, there is a nice study showing that it can be tremendously helpful for persistent pelvic pain. And then another dorsal column stimulator also showed that can get some benefit with pelvic pain. And, I can say I've found some benefit for patients with these stimulators, which, when they're appropriate and everything else fails, can be tremendously helpful. But we do approach them in a stepwise fashion. Other things, peripheral neuromodulation, there's something called GammaCore, which is a vagus nerve stimulator. Okay. It's used mostly for migraine and cluster headache, but it can also be helpful for gastroparesis, which happens with a lot of pelvic pain, endometriosis especially. And it can also be helpful for PTSD, using that a lot, and stellate ganglion blocks. So when we were speaking before about the sympathetic nervous system, that fight or flight response, it's not uncommon at all for me to see someone who's had endometriosis for a while, and the flares of endometriosis make them feel crazy. And they acknowledge it's not like they're anxious thinking about something, but their body feels anxious. And how do you stop that process? Because when you're feeling anxious all the time, but there's no good reason psychologically for that, how do you stop that? It comes back to the sympathetic nervous system. And so the stellate ganglion, it's a bundle of nerves in the neck off to the side, which controls the sympathetic tone to the brain. And we can block it in the office with local anesthetic. It takes about 30 seconds. It reboots that part of the nervous system, and that can be helpful for days, weeks, or longer. We use it for that. We use it for PTSD. We use it for headaches. It can be helpful for a lot of different things.
Amazing.
Dorsal root ganglion, produced by Abbott. It's also a spinal cord stimulator, but rather than targeting the posterior columns like traditional spinal cord stimulators, it goes to the DRG. Wow. Typically, it'll be the DRG of L2 and S1 that's targeted. My preference is to understand the genesis within the nervous system of the pain before doing one of these things, because I don't like to just sort of blanketly stimulate everything if we don't need to. So if it's more of a pudendal distribution, you don't necessarily need the L2. And if it's more of an ilioinguinal genitofemoral distribution, you don't necessarily need the S1.
Amazing. I have learned a lot from this conversation. I want to mention one new technology that I have now in my office that has been a game changer for some of my patients with chronic hypertonicity in the pelvic floor or just chronic muscle spasms. Also, some of my patients with severe stenosis and osteoarthritis in their cervical spine. We've brought in the win-back to car therapy technology, and it is a form of radiofrequency that we can use in different applications with different sensors and different heads. And one of the amazing ways is actually with a watch or like a bracelet on our forearm, and we can transmit the current through our hand. And I've been able to use this internally with patients, with pelvic floor patients, male, female, who are very hypersensitive to touch and aren't really able to tolerate some of the traditional manual therapy release. But what I can do with the Takar therapy, with the win-back Takar therapy, is apply less force and allow the current to stimulate the tissue and allow it to relax. So it's been really amazing for me. So I wanted to mention that because it has been a game changer. Dr. Siefferman, this has been a very enlightening conversation. Do you have any final recommendations for patients who are seeking pain management?
I think the biggest challenge that patients with pain have is finding a provider that's a good fit. And everyone talks about doctor shopping as a bad thing, but you have to find someone that fits you, someone that hears you and gets what you're saying. And it has to viscerally seem right. Generally, patients will know. Even if you don't find that good fit right away, you will get a lot of opinions as you look for that good fit. And it can be helpful to get a broader perspective from compiling all of these opinions. So I'm sorry it is such a difficult journey. I'm sorry there's so much inconsistency between pain providers. And it really is, I make the analogy, it's like online dating. It's almost like there's a lot of riffraff to sort through until you find the right one. It's tough, but don't give up hope. Keep searching. There are people out there that will be a good fit for you.
I love that. Those are great final words. Thank you so much again for your time, Dr. Siefferman. Thank you, everyone who is listening. For anyone who is interested in learning more about Win Back to Car Therapy, we are having an open house here at Inspira Physical Therapy, 219 Fifth Avenue, Brooklyn, New York, in between Union and President on Tuesday, November 15th from 5 to 7. It's free. I'll be here with some people from WinBack, and we'll be answering questions and doing some demos, so everyone's welcome. Dr. Siefferman, thank you so much for your time.
Thank you. Have a good evening.